Zeiner is a clinical neuropsychologist here in the Bay Area. She was originally trained as an experimental psychologist with a doctorate in physiological and comparative psychology from the University of California at Berkeley. In 1978, Dr. Zeiner became assistant professor in the Department of Neurosurgery at Oklahoma Health Sciences Center. She and Dr. George Prigatano began a milieu-based treatment center. There, she developed cognitive retraining modules and worked clinically with neurologically impaired people. After 10 years of clinical and research work, Dr. Zeiner established the first brain injury treatment program in Denmark with Annelise Christiansen. She then respecialized in clinical psychology and worked at Langley Porter Neuropsychiatric Institute at UC San Francisco. In 1989, Dr. Zeiner became a clinical neuropsychologist at the Palo Alto Veterans Affairs Health System Comprehensive Rehabilitation Center and TBI unit. In 2005, this unit became one of 4 national lead centers for the traumatic brain injury and polytrauma centers in the VA system. In May 2007, Dr. Zeiner became a clinical neuropsychologist attending for the Neuropsychological Interventions Clinic at the Palo Alto VA. At Palo Alto's VA Neuropsychological Assessment Center and Intervention Clinic, the NPI, cognitive training embedded in the individual therapy is given to patients with neurological impairment. Crater therapy is a modification of standard therapy and consists of 4 points of behavioral intervention and training on an audiovisual handheld electronic aid. Today, Dr. Zeiner will be sharing with you information on her crater therapy approach. And without further ado, Dr. Zeiner.
Not to panic, but I have 111 slides. And it's not on your little jump drive because I keep modifying it, and I miss the deadline. So what I want you to do, if you'd like a copy of this, and I want you to want a copy of this, they'll post it to the website. This is great. The reason why there's 111 slides is because if you printed out 2 slides at a time, you're going to have a workbook on how to do crater therapy. And that's both for therapists, it's also for family members who can help survivors and actually use this. What is it that I'm going to do to you today? Well, essentially, I'm going to try and get you to modify what you're already doing in cognitive retraining and therapy with patients. And it's not specific for patients with traumatic brain injury, although that's where it came from. It's actually a method that can be used with anyone who has a neurological impairment and still has some learning capacity. I call it crater therapy because I've been talking about it for years as the Alliance and Resilience model, but then we had to apply for a grant, and I needed a better name. And there are 6 principles, actually there were 4, and so I felt like the movie Rosemary's Baby, we actually took Scrabble things and put them out and tried to make words so that people could use it as a mnemonic for training. And what we just came up with crater, which you're going to become overly familiar with today, and found that actually having the mnemonic helps people in the session because you can get overwhelmed with the amount of things that are occurring. One of the things about crater therapy, why didn't I just use modifications like cognitive behavior therapy, is that this is a therapy which is actually based on the symptomatology of patients. It actually uses it in a very integrated way. Now, not to panic, you're going to see this slide twice. And the reason you're going to see it twice is because these are 10 things that I want you to know about crater therapy. So what I'm going to tell you about the 10 pieces is that this is a way to embed cognitive retraining in a form of individual psychotherapy. I want you to pick the cognitive deficit that's most likely to elicit stimulus overload, complete overwhelm in a patient, and then teach them a compensatory strategy which they will perform every time they have a catastrophic reaction, every time they are cognitively overwhelmed in the real world. If it's present, I want you to always address fatigue first. And I say, if it's present, it's almost always present. I want you to address fatigue first because you have to regularize the day-night cycle and routinize rise time, sleep time, meal times, and med times. Naps, anything like that that has a time component to it. You're going to form physiological anchors, and those anchors are going to allow the performance of a cognitive strategy and remove the burden on memory and initiation for patients. You need to address any cognitive deficit that leads to what Kurt Goldstein called the catastrophic reaction. You link the performance of the cognitive construct to the catastrophic reaction when it occurs in the community, and that's the main way in which we affect generalization into the community. The therapy consists of having patients learn. One of the things about Crater is that it is, for any patient with a neurological impairment, and because of that, what we want to do is have the patient learn their full-blown catastrophic reaction. It could be rage, it could be crying, it could be running away, whatever the overwhelm is when people are stimulus overloaded because of their neurological deficit. Later on in the therapy, they learn to pick up when they're going into a catastrophic reaction sooner and sooner. And so they might pick it up because they're beginning to get irritated. But that's actually further down in the therapy. Every session that you have with a patient is about learning. It's about their new learning characteristics, the size of the information that they can digest in a bite, how often it has to be repeated or overlearned, and how long it takes overall. In some ways, we have to overlearn the cognitive strategies because they need to be available to patients when they're overloaded in the community, when they're completely overloaded and cognitively narrowed. They can't come up with a creative idea. This needs to be overlearned so it's automatic. The same therapist sees the patient and the patient's family member. That's a change from how most people work. And we tend to use a PDA and software combination. We use Pete. You're going to hear about it quite a bit. And we use it for a couple of reasons. We use it as bait to get patients into therapy because they think this is what's going to change them and cure them. And everyone likes technology, and so do the therapists, by the way, that I've been training. So we use it as bait to get the patient into therapy, but we also use Pete because it turns itself on in the patient's pocket and in their own voice tells them to do something. So it removes the burden of initiation and memory from the patient, and it differs from an electronic calendar with alarms. One of the things I do want you to do, though, is to never consider the prosthetic to be the agent of change, the therapeutic agent of change. So here's another way to say what it is I'm going to be talking about. You need to base what's being compensated for first on what gives the patient the most frequent grief. It's based on the symptomatology of the neurological insult. It's based on the fact that fatigue is almost always present. It's based on the patient being overwhelmed with information coming too quickly. Slowed information processing is probably one of the primary things we work with. This leads to the catastrophic reaction. What is the catastrophic reaction? I'm going to talk about it a little more. It could be anger, it could be tears, it could be running away, like bolting, it could be freezing, it could be confusion, or it could be helpless laughter. There are 6 possibilities, but any one patient will only show 1 or 2 consistently. Okay, so it's relatively easy to treat. Secondly, we want to link the performance of a cognitive compensation to either the catastrophic reaction that they show in the environment or one of these physiological anchors in their routine. How are we going to do this? Well, Crater has several characteristics. One of them is we embed the teaching of the cognitive construct in a therapy that, first of all, externalizes the symptom that they're experiencing as belonging to demon brain injury. Probably the only psychologist in the United States that uses words like demon. But it's a very, very helpful way of explaining to a patient what's going on. It recognizes that anger at loss is not pathological, but is actually pretty useful if it's directed properly. So a large part of Crater is the therapist doing a jujitsu and making anger that naturally occurs at loss directed externally, where? At demon brain injury and how to limit its impact on their lives. Not at family members, not at the therapist, and not at family. And if you don't redirect the anger somewhere, that's where it's going to go. And Crater therapy also involves redefining the patient's source of self-esteem. Many of our patients can no longer compete. They're not fast enough, they don't have good enough memories, their information processing is too slowed. They can't be the most competitive winner anymore, and that's where many of us take our self-esteem from. Instead, we're going to move to a resilience model and say, I take my self-esteem whenever I perform my cognitive strategy properly, whenever I cope most effectively. There are a couple of don'ts. Don't blame a patient for lack of motivation when cognitive retraining isn't being successful. It usually means you've entered the cognitive continuum at the wrong point, and you need to get to an earlier stage. Don't assume that the PDA and KEEP software that we use is the agent of change. That's not what's causing the change. Understand also that why a cookbook method of cognitive retraining techniques simply won't work, especially if it's based on diagnosis rather than symptomatology. And I have found in my career that cognitive retraining that's assigned by diagnosis or level of severity of injury is not very effective. The problem is that that's where the evidence-based practice is. Cognitive retraining is for people with comorbidities. Don't ignore order effects. I'm actually going to tell you what order in which to approach patients that Crater works best. And do believe in some way that the personality and prior technology use can impact who's going to use a PEAT or a PDA or an assistive technology device. I'm going to quote from Kurt Lewin. And he said in 1946 that research that produces nothing but books will not suffice. And I was going to go through a long discussion, not so long actually, about 5 minutes worth, that actually talked about the evidence-based practice for cognitive retraining. A lot of that started with Cicerone in 2000 and looking at a lot of studies and applying class 1, class 2, and class 3 types of design, and the conclusion was essentially that overall support exists for the effectiveness of several different forms of cognitive rehabilitation for people with stroke and with TBI. There have been updates since then in 2003, in 2005, and in 2008, and when you actually get the slides, you'll be able to look up those studies. All of these studies, however, focus on specific cognitive rehab techniques and specific diagnostic categories. A couple of them have addressed the fact that patients do improve, but if you test them at 3 months later or 5 months later, you often see no use of the cognitive retraining, even though it had the benefit of improving people's performance, unless you give refresher courses or retraining. Among many of these very specific focused evidence-based cognitive rehab studies, there are numerous references to confounding variables. What's a confounding variable? Slowed attention, slowed information processing, and an inability to multitask in social situations. These are all considered things that mess up the study of people's performance when they have a brain injury. Actually, I'm going to contend that the so-called confounding variables of fatigue, slowed information processing, and variable attention are not only not elements of variance, but rather they're precisely what we should be addressing in the first place in cognitive remediation. The point that I want to make is that since 2000, almost all of the studies have applied these Class 1, Class 2, and Class 3 studies and very specific levels to very specific populations. Why is this a problem? Well, the first reason it's a problem is that it provides specific techniques for very specific patient populations whom we don't treat. Most of our patients have comorbidities. They can have post-traumatic stress disorder, they can have depression, they can have anxiety, in addition to cognitive disorder NOS, in addition to the brain injury itself. Or they could be aging, or they could have a drinking history, or they could have something else that is interacting with the brain injury, and they're excluded from these studies because they have confounding variables that mess up the study. And secondly, because this approach moves us clinically away from the following set of studies, the studies that show us that inpatient rehabilitation, if you give it to people acutely, and they're at a Rancho 4 or 5 at the time of their injury, does in fact lead to better cognitive and functional status 1 year post-injury. But even more importantly, there's a considerable body of evidence that holistic outpatient treatment programs that include cognitive remediation in an integrated therapy increase any patient with acquired brain injuries return to either a work or school situation and increases their community integration. With George Prigatano back in 1984, I published one of the first studies, which you're not seeing, that actually looked at an integrated milieu-based therapy. And Pam Klonoff and her team and Jim Malik and Cicerone all have published this, continue to publish the results. A study by Klonoff in 2007 looked at the success factors. Who is successful after milieu-based or holistic-based therapy in getting back to more functional either work or school or just any function in the community? And what they found was that people who did something about their the slowed information processing, something about the way in which they visually scanned, did something about their memory problems, all of these, if you had the greatest gains in that, you had the greatest gains in function. So when I looked at a lot of this holistic information about what was it that resulted in a better outcome in the community, these were the things across the studies that resulted in benefit. Patients who had a positive working alliance with their therapist. The better the alliance, the better the outcome. Patients who were able to pick up cognitive remediation and skill remediation techniques and perform them uncued or unassisted, meaning not by the therapist, not by another person. And people who had cognitive interventions and therapy combined. All of these resulted in better outcome. So I think this body of evidence from the holistic programs is really clear, relating success in the community, success in work, success in school after a brain injury, when cognitive remediation is integrated with psychotherapy, that the same techniques worked for a number of acquired brain injury, traumatic brain injury, stroke, mild cognitive impairment due to aging, chemo brain from toxic effects from medications that are used to fight cancer, cardiac bypass patients who have experienced changes in memory and concentration, a wide variety of patients. And there's clear evidence that the patient with cognitive, the ability of the patient with cognitive impairments to use the remediations unassisted, to ally with their therapists, and to reduce the effects of slowed processing, all of that are correlated and predictive of higher functional success into the community. I'd like to make one little side riff about prosthetic devices, because one of the biggest things I've run into, I'm a techie. We use the PEAT system with a PDA, and we're actually developing that much further. I believe in Silicon Valley and the devices to make our lives better, but I often find that people confuse the device as the thing that's fixing the patient, the thing that's going to help the patient. And I want to talk about a little bit about Marcia Scheer, who's done some brilliant work showing that in patients with TBI or stroke, you could divide them premorbidly into sophisticated users. These are people who use computers and PDAs prior to their injury. Minimal users, these are people who use cell phones, CDs and DVDs, maybe an iPod. And non-users, these are people who know how to press the button on their microwave, and they use regular phones. And that if you looked at who used a device successfully after their brain injury, she found three important things. One is that if you emphasize how much a patient needs the device, if you emphasize the amount of deficit, it gets you nothing. It has no impact whatsoever on whether or not a patient's going to use the device. If the person premorbidly was a sophisticated user, used computers, used PDAs, for them, they wanted more freedom and autonomy than non-users post-injury. So for them, the sell for using a PDA is the device frees you up from other people's control. If you were a minimal user before your injury, minimal technology users, the appeal of the device for them is it brings them closer with other people. So you emphasize that in using the assistive technology, social bonding. With this in mind, I want to now go to crater therapy, which is the modification of what you're doing now. And I'm assuming that most of the people in the room are sophisticated users of cognitive retraining and therapy, that you are all therapists with a good background in treating traumatic brain injury. So I want to basically say, what kinds of symptomatology am I talking about in crater? What kind of emotional and personality changes occur to people with acquired brain injury? And I'm going to say that there are two main sources of change. When questioned, the family members say that fatigue and anger for them. They mention anger and fatigue as the greatest source of change. That's when they say someone's changed in personality, they're saying he or she is tired, he or she is angry. Secondly, and that's not the same as a true personality change. A second source of personality change comes from the patient's neurological condition itself. After World War II, a German neurologist named Kurt Goldstein described what he called the catastrophic reaction that he saw in people who had a brain injury. He talked about people laughing hysterically when they were overloaded, or crying hysterically, or running away, or breaking out in rage and anger when they were overloaded. All of these were emotional responses that people with a neurological impairment gave when things were coming at them too fast. It's really important to notice that Goldstein felt that these reactions were qualitatively different in how frequent they were given, but not their form. So someone doesn't give a response, an emotional response when they're overwhelmed that looks like that's specific to people with brain injury. It looks like everyone else getting angry. It's what causes it and how frequently it's given to particular situations that defines it as a catastrophic reaction. These same responses, one or two of them, are consistent in a particular patient. Over the years, I've added two to Kurt Goldstein's list. One is confusion, where patients jump into action to do something, but they haven't got a clue what they're doing. And the second is freezing. Patients describe this as, I went completely blank. I was like a deer in the headlights. So I'm putting that on the list of what Kurt Goldstein thought of as behaviors that people show when they have a neurological impairment and when they're overloaded, when people are talking at them too fast, when too many things are being required of them, when there's a memory component that they can't handle, when any kind of situational overload. So it becomes freezing and blocking, confusion where you jump into action without seeking clarification, crying, laughing hysterically, running away, or the most common one is anger.